We now want to welcome Dr. Alberto Espay and Ben Stecher. Please remember that we will answer your questions after our final break, but I can answer, or I can submit a couple of questions during the presentation if it seems pertinent at the time. So remember to place your questions in the chat window that you'll find at the bottom of the screen. We've had a number of questions come in for Dr. Dobkin, so we know that chat functionality is working. Dr. Alberto Espay is a professor and endowed chair of the University of Cincinnati's James J. and Joan A. Gardner Family Center for Parkinson's disease and movement disorders. His research efforts have focused on the measurement of motor and behavioral phenomena in and clinical trials for Parkinson's disease, as well as in the understanding and management of functional movement disorders. He and his team recently launched the Cincinnati Cohort Biomarker Protocol, about which he will give us an update today. He currently serves as the International Parkinson and Movement Disorders Society as chair of its task force on technology and secretary of its Pan-American section. Dr. Espay also serves as the medical director of the Parkinson Support and Wellness Board of Directors. We are grateful for his service and support. Benjamin Stecher is a Parkinson's patient turned Parkinson's activist and advocate who works alongside Dr. Espay. Ben has traveled the world meeting with leaders in research and development in the Parkinson's disease field and advocating for a new focus in the approach to research and treatment. Together, they worked on Brain Fables, which will make you rethink what you know about degenerative brain disorders. He told us that Brain Fables is a call to refocus on understanding living and aging to create the personalized treatments each affected individual desperately needs. Thank you, gentlemen, for joining us this morning, Dr. Espay and Ben. Thank you.
Thank you, Chris. Thank you for having us here. Thank you to the Gardner Center. Thank you to Parkinson Support and Wellness Center. Thank you to the sponsors, and thank you to our Chris for hosting this and inviting us to this event. And thank you to everyone who's listening on what we have to say. So my name is Benjamin Stecher, as Chris just said, and I'm here joined by Dr. Alberto Espay, my partner in crime in this book, Brain Fables. And I guess we're going to start by just quickly introducing ourselves, kind of telling our backgrounds, telling our own stories that led us to this book. And then we'll shift to interviewing each other. And then we'll take any questions that anyone might have towards the end of this talk. So I'll start, I guess, just by asking Dr. Espay. I first got in contact with you towards the beginning of 2019 or the end of 2018. I was wondering, though, if you could tell me your story leading up to that point. What brought you to all the conclusions that came to fruition in this book, Brain Fables?
Well, thank you, Ben, and thank you, Chris. And I'm delighted to be here with you and to share this special virtual podium. I always enjoy being with you. I wish it were being in person, but I think we were destined to meet. In many ways, we were both in different traveling programs, traveling from the intellectual perspective. My travel, because I think yours is such an interesting one too, but mine was one that began to change in 2015, and this is, I consider, a pivotal year, perhaps the year that ended up becoming what I would think is the first series of events that led to what the book ends up summarizing as written by the two of us, with the angle that this was a year when we as a field had a new criteria for Parkinson's. And I was asked to present to an audience in Buenos Aires about the reasons why this particular diagnostic criteria was an improvement upon the older one. And ostensibly, of course, it was all about how to match these two criteria and say the new one is better. But it got me thinking that it was prettier in language, but it did not represent an evolution of our thinking. This really is what I think is a major problem. We have insisted that somehow neurologists are the ones that own the truth as to what is and isn't a disease, and make a diagnosis on the basis of what ultimately amounts to a committee of experts. If we have enough documentation built up of a variety of different symptoms and signs, and those are ultimately following along the path of the clinical pathologic criteria, meaning you have the clinics and then you have pathology that documents that which we identify as representing Parkinson's, then we say we have enough evidence to call it. And the trouble is that the kinds of things that we've used to define diseases have been common denominators of many diseases in reality. It just so happened that our minds are best suited to get into concepts that we can understand. So the problem in 2015 was we were insisting that we still knew what Parkinson's was, and we just had better language for it. In many ways, it was a backward step because it was a lot more inclusive into the same label. In fact, cognitive impairments and dementia are now not exclusionary of the diagnosis of Parkinson's disease, for instance, because on autopsy, we see the same Lewy pathology. The second event, and with this I'll pass it back on to you, is that at about that time, a very wealthy individual approached me with the concept that perhaps we needed to invest in make a transformational gift to be able to really make progress. And he was the first one who asked me the question, what should we do? And that is such a different question to what can we do given this limited funding, which is, of course, the way I have always operated. I've always operated on the assumption that we can do research provided we have a specific request for applications, which is a program that fulfills a mission, and you have to have a hypothesis, and you need to know what is it that you will be expecting. This one was, what should we do? Money being an obstacle. And I realized the answer was very different. And for the first time, I realized that we just kind of need to understand aging, and why is it that we age in funny ways, some of which we have the name of Parkinson's for. And I began to think that perhaps we were, in our attempt to reduce the universe of Parkinson's into something that we could make sense of, that we were failing our patients. We were in the false sense of security that our concepts were in fact reasonable, rational, and biologically valid. And at that point, I began to look at the biology of it. And that, of course, is what gave rise to the themes of Brain Fables, which essentially, as we can discuss next, goes through each of the pillars of how Parkinson's came to be. And by looking at the same data that gave rise to Parkinson's, we realized that perhaps that data could be construed in completely different angle. And that's why we came away with the idea that there is a hidden history of Parkinson's, and that's the one that we need to understand and recognize if we're to make progress.
Awesome. And yeah, I'll just quickly give a sense of my own background so you get a sense of how our stories converge, and then we'll continue on with the story of Brain Fables. So I was living and working in China at the time of my diagnosis. I was 29 years old at the time. I was working for a pretty big education consulting company. When I started to realize that the shaking that I was seeing in my hands and my legs was not going away. It was getting slowly worse and slowly worse. And I had an aunt who was a doctor herself. She was a GP. I came home one day on a trip from China, and she noticed that my hand was shaking, and she booked me a appointment with a movement disorder specialist, and I got my diagnosis almost right away. Now, at the beginning of my own journey, I didn't really know what to expect. I didn't really know anything about this disease. The only kind of reference points I had were Michael J. Fox and Muhammad Ali. Aside from those two figures, the word Parkinson's didn't mean anything to me. So I started to research. I started to dig into the literature. I started to read all the funny words that you come across in medical textbooks and in medical journals. And I slowly started to build up my own understanding of this disease. And at the beginning, I was very optimistic about everything that I read because it seemed like the field had figured this disease out. It seemed like we knew what the cause of this disease was with these protein accumulations in people's brains. And we had all sorts of treatments in the pipeline that were coming around that were going to solve this disease pretty soon. As I dug a little bit deeper and as I got to question a lot of the people in the field, and this is something that I did on a website that I started called Tomorrow Edition, where I interviewed about 80 experts in the field, I started to realize that this rock solid foundation that we were building was not as rock solid as I thought it was. It was actually quite flimsy. And a lot of our conceptions about what this disease is on a very fundamental level was not what many of the experts claimed it to be. And then I came around to some reading to Alberto's papers. I had a friend of mine who's actually a neurologist himself now in training, a friend named Leonard Sokol, who was, I think, a resident here in Cincinnati at some point, who started to tell me about this guy named Dr. Alberto Espay. And further down the road, so I get treated now. I'm actually right at the moment here in Toronto, Ontario, in Canada, and the head of the movement disorder clinic here is a guy named Tony Lang, who Alberto trained under. And I started to talk to Tony about some of the ideas that I was percolating in my brain, and he said, "You need to speak to Alberto. I think you two will connect very well together." And it was that, and it was also another article that I started to read from that was written by Tony and Alberto that then connected me. That was like the last straw, and I said, okay, I need to reach out to this man. I need to see what he's got to say. So then I sent him an email, and he very graciously responded. We had a lot of exchanges that eventually grew into this book. But I guess, Alberto, could you elaborate a little bit more on that paper that you and Tony wrote and some of the work that you had done in the past about biomarker studies that led you to the conclusions that we need newer and better biomarker studies if we're ever going to make progress in this disease?
Yeah, no, absolutely, Ben. I'm so happy that happened to have connected us. You also mentioned, by the way, before I go into what you asked me to, that ideas are powerful, and how important it was that you ended up being motivated to come in to Cincinnati to see what we were doing and to ultimately connect into what resulted in the book and our CCBP program because of the articles you were reading, and one particular article that you referenced, which was titled Parkinson's Diseases in the 2020s and Beyond, Moving from Clinical Pathology Convergence to Systems Biology Divergence. a mouthful, admittedly. But the idea was that we needed to finally walk the talk about Parkinson's not being one disease. We've been paying lip service to the idea that Parkinson's is many diseases. But we ultimately revert back to form because that's how we are accustomed to dealing with Parkinson's a disease, but we're not really dealing with Parkinson's as a disease that's unique to each individual. So in 2017, we published an analysis of the biomarker development efforts that at the time were the major one in North America was the PPMI, still probably is the most important Parkinson's Progression Markers Initiative, Michael J. Fox Foundation funded initiative. And in Europe, it was the NOPA, de novo Parkinson's. But it's a similar idea, people who were diagnosed with Parkinson's and from that very early stage then were followed carefully with clinical measures as well as with a variety of tests, some of which in blood, some of which in spinal fluid. And so what we did in that analysis is to ask the same question of PPMI between year 1 and year 2, and then ask the same question between PPMI and the NOPA at year 1. And it turns out that the answers were different. That was damning. How could we be building a biomarker program? And by the way, biomarker parenthetically means a test that identifies a biological mechanism that we think is related to the disease in the individuals affected. Well, if we are validating biological signals of Parkinson's, why should they vary within and between cohorts? Shouldn't they be the exact same ones? So if we're identifying biological truths, shouldn't they be the same, and again, within and between cohorts? And that was, I thought, an indictment of the process. So where is the problem? Well, the problem is that we are still insistent that when we say you have Parkinson's, as Ben may have been told, and of course you and the audience would have each experienced that, that is the truth. So a doctor like me were to say at the bedside, well, based on my knowledge and the observations that I have made, you have Parkinson's. Trust me, I'm an expert. Sorry, I cannot do a biological test to prove it to you, but I'm applying stringent criteria that my forebears have developed, and you can bet that this is Parkinson's. Yeah, you'll have a little bit of a different path forward. Here's our lip service. This is a parenthetical comment we make. You'll have a little bit of a unique pathway, but ultimately this is Parkinson's. And because of that, then the biomarker programs have been made of people who have the diagnosis we claim. So that becomes the truth. That's what in statistical terms is the independent variable. That is the established element, and we want to find out what other dependent variables correlate with the independent one. The independent is a gold standard. The analyses are anchored on an independent variable. Well, of course, if Parkinson's isn't one disease, you will find variability in any study that you do. If you find something that is statistically correlate with people that are defined as having Parkinson's by us, and then repeat the study with another group of people that are defined by other doctors as Parkinson's disease, the results will be different. And then, of course, we are finding biomarkers of a disease, but not of individuals. So that is the convergence that we began to realize we need to move away from. We need to find divergence. We need to identify what is it about somebody like you, Ben, that is unique about the way you develop this form of Parkinson's that's different to others, because therein lies the source of treating your disease. If we can identify why you had this problem, then we could open us to therapeutic avenues for your disease, which, if indeed you have a different disease to others, which is the expectation, that approach will not work for just about anyone else. And this is why we have failed consistently in clinical trials. And you can mention about that assessment of all the trials in Parkinson's disease.
Yeah, and just to add on to your point about how individual in nature this is. So when it first struck me that we were dealing with more than one disease, and where I started to kind of lose a little bit of hope in what I was seeing in the clinical trials that were ongoing, was in 2016 when I attended my first World Parkinson's Congress. And if anybody gets a chance, I'd highly recommend you to go to this conference. But I was still fairly early on in my disease progression. I was diagnosed in 2013. So in 2016, I really wasn't that symptomatic. My Cinemet was helping me fairly well. So I went to this conference not knowing what to expect. It was kind of my first introduction to the world of Parkinson's. And I saw in that conference hall, I remember just walking around the conference hall, looking at all the different patients that were there. And there were about 1,000 different patients that converged on this one conference center in Portland. And I walked through the halls looking at all of them. And I noticed that no two of them had the exact same set of symptoms. Every person in that conference hall had a different kind of flavor of this disease. And it started to clue into my brain, if everyone here presents in such a radically different way, how is it possible that we're dealing with this one disease? How is it possible that this thing called Parkinson's disease is one disease that and any one therapy will come along that will be able to appropriately treat it? I also started to get more experience with clinical trials, both as a participant and started to engage in some study design as well. I was a participant actually in the PPMI study that Alberto mentioned before. And when I started to read about Alberto's work, I dropped out of that study in favor of pursuing the line of work that he's doing right now. But I was also involved in a couple other clinical trials early on in my disease progression. Most of them were just observational trials. But I noticed that they clustered us all together under the same bracket, under the same bucket, really. That every patient in that trial was treated the same. We were observed in the same way. We were given the same treatments. We were treated as if we had the same thing. And that just patently didn't seem to make any sense to me at some point. It seemed to, for anybody who's been in this long enough and who's seen enough people, it just doesn't make any sense to me how we think that any one therapy will come along that will treat everybody in this exact same way. And this gets me to the point that I want, like Alberto, to try to expand on. How is it possible that we've gone so long in this field of neurology without really walking the walk? I mean, a lot of people in the field talk about how heterogeneous this disease is, how many different forms of this disease there might be, but yet we still recruit everybody with Parkinson's into the same clinical trials. Why is it that it's taken so long, and still to this day, the field is kind of hesitant to really move in the direction that I think you and I both agree we need to start moving in?
I think if I were to boil it down to one thing, and that would be relevant to patient groups, patient advocacy groups, is the idea of hope as we conceive it. We hope to cure Parkinson's. It's a beautiful hope. It is irrational. How can we transform that into rational hope? How we can say we can begin to cure Parkinson's one individual, one subtype at a time, rather than saying we're going to cure Parkinson's? Because I think that's what's keeping us doing the same thing. We're saying, well, we failed here, but look, this one is going to do it. We have been saying to ourselves, really, that we're doing different things. We're applying different strategies, and one of these strategies will work. We're applying different interventions, but the strategy is the exact same across all the studies. And I think that a big part of the reason is that we hope to cure Parkinson's. It's a beautiful hope. It's a hope that I had too growing up in the field, but I recognize it is not tenable. So I think that what we need to do, and if there is one homework for us to do collectively, is to figure out what will it take culturally to change curing Parkinson's as a slogan, as beautiful a slogan as it is, to something that still reflects we're going to be doing cures, but it's not going to be curing the whole thing at once, because nothing can cure the whole thing at once. It is too many things that we're trying to pigeonhole into one. Just like cancer, nobody says we're going to cure cancer, but look at the progress made in the field of oncology and look at how many people with cancer survive now, when in the past everybody was dying. Right? It was not in the not too distant past. Why? Because at some point, people began to think that cancer in the breast was not one disease of the breast, cancer of the liver was not one disease of the liver, etc. And how we can learn from those cultural changes and apply them to our field, so that even if we say we're going to cure Parkinson's, that we don't mean it in the way that we one day will somehow magically, with a given set of strategies, somehow cure everybody with Parkinson's. It won't happen. So that's kind of, I think, and Ben, you can try to perhaps lead the task force to try to figure a way to make sure that shifting culturally is not depriving us of hope. Because at the end of the day, we all want to continue having hope, but we want to base our hope in biology, in rational evidence, not on just hope.
Yeah, and for everyone in the audience, this is something that anybody can help us with. The struggle that we face now is really as much about marketing and storytelling as it is about the science behind what we're doing. Because frankly, curing Parkinson's is a sexy slogan. It's something that is easy to put on a bumper sticker. It's something that you can call your organization with and everybody in the world can understand it. It's much harder, and it takes a lot more time to explain what it means to subtype people and find biomarkers and then match them to therapies and then all those other things. So the struggle that we face, and this is something that I've found kind of paradoxical, is that even neurologists, even the people who understand the brain the best, can be duped by a good story. A good story has a lot of power, I think, over humanity and look at our history. It's filled with tales of people who believed a certain thing or another, and they pursued that to the nth degree, and that led them in one way to ruin, or it just led them down the wrong path. And this is very much the reason for the title of our book, Fables. The stories that we tell about the brain are as important as the realities that we encounter when we examine patients at the bedside. It's those stories that have a very binding effect on how the whole field operates. And there's all sorts of stories that we go into in the book, but one, I think, classic story that I think I'd like Alberto to elaborate on a little bit more is a story of something called Brock staging. Brock staging is something that seems to have dominated the narrative of the field for the past 2 decades. And Alberto can elaborate on this much better than I can, but it seems to be a very enticing story that everyone has kind of fallen into. And it's led us to where we are today. But I'll hand it over to Alberto, who can tell this much better than I can about how its origins and how it's gotten us to where we are.
Sure. Well, that story is nicely outlined in Brain Fables, but essentially, German pathologist, Heiko Brack is his name, had at his disposal not more than 60 brains of people with Parkinson's and another 40 or so brains of individuals that ostensibly had no Parkinson's. And what he did with those brains, just over 100 brains, is that he stained them for synuclein, which is the constituents of the Lewy bodies. I'm going to say this is the Lewy bodies, and I'm actually bringing this because I want to make a point later about what Lewy bodies are, and we can talk about that in a moment. But stained them in the brains, and then decided to look at the patterns of each of the brains. And there were some brains where there was very little immunostaining, that is the alpha-synuclein revealed by this particular chemical. And then there were brains where there was a lot of it. And he organized the brains from those who had very little staining to those that have a lot of stainings, and created a story, very much as Ben is saying. Well, here's a story. From people who have very little to people who have a lot, then what you have is you can connect the dots, and eventually you kind of come up with something called stages of progression. And it interestingly showed in that sort of beautiful story he created that it was stage 3 when you begin to see a staining in the substantia nigra, which is part of the midbrain, an area in the brainstem where the neurons that make dopamine are. So he then said, oh, well, we have these stages before we develop the symptoms that give rise to the diagnosis of Parkinson's disease. And then, of course, there are things that follow thereafter. So he, in one study that became incredibly influential, was proposing essentially 3 things. The first thing is that here's the unifying force that unites Parkinson's, this stuff. And the little, when you have very little, you are in the stage 1, and then when you have a little bit more, you're stage 2. Stage 3 is when you have a lot more, and that's when we clinicians, we doctors can recognize it, and then of course you have a lot more thereafter. The second concept he created with this study is that when proteins are here in stage 1, in order to get stage 2, they are moving. He created the idea of spread. Now, think for a moment that we're talking about 60 brains. In fact, he is making this, and these, of course, are studies done at one point in time. Remember, these are brains of individuals who died before, some of which had Parkinson's, some didn't have Parkinson's because there were a number of control brains. He was making the case that to get from 1 to 2, there had to have been a movement, a spread. So that second implication became the basis of the prion hypothesis of Parkinson's, that this stuff acquires some form of virus-like properties, that this is the problem because it can replicate, it can propagate, and it can be transferred between cells. And the third thing that he created is that this was both necessary and sufficient for inducing Parkinson's and degeneration. This is why, since its publication in 2003, this beautiful story is so compelling, is so logical, is so beautiful that it has captured our attention and it hasn't let it go. We insist that Brack had it all right, that yes, this is one disease. Secondly, it is propagating or evolving because of the toxicity of something that propagates from one cell to another. And third, that this and only this is what we need to get rid of because it is the cause of the problem. And all those 3 are biologically false. And we have to reject the Brack hypothesis, but it's super hard to do that because it's such a beautiful story.
Yeah, and I want to take a more optimistic turn and talk about what we're going to do in the future to lay a new path. But there's one other point that I want to make sure that we make, and some of the other important lessons that we've learned have come from kind of the sister fields of Parkinson's, which have been Alzheimer's and even some recent studies in Huntington's and some other diseases, where we're learning a little bit more about some of these protein folding disorders and what leads to these protein folding disorders and the misfolding of these proteins. And I guess turning to Alberto again, can you elaborate a little bit on some of the more recent lessons that we've learned from some of the more recent trials, both in Parkinson's and targeting alpha-synuclein, and in Alzheimer's targeting targeting the amyloid plaques that build up in those brains?
Absolutely. So that's a great segue, because I was thinking, well, if this is the problem, then we should see a direct relationship in all the studies between how much of this there is and how bad things are. And it turns out that there isn't that relationship. There is very little relationship between us. Most of the amyloid studies, by the way, amyloid is a state of the protein, and so Lewy bodies are amyloids. They are proteins that have acquired what's called a cross-beta conformation. They're really, really stable and can not do anything. That's why they are still available when we do autopsies. They are still there for pathologists to identify. So it turns out that there is no relationship between how much of this we have and how bad things are. And in fact, in the studies, anti-amyloid studies in Alzheimer's, the more of this we clear, the worse some people can be. Nearly 40% of the trials have shown that those in the treated arm, where there was a great deal of clearance of this, the worse they in fact do compared to those in the control arm, the ones that are getting placebo. What we've done recently is we've looked at a very, very large data set of patients with Alzheimer's. Again, the understanding of Alzheimer's is very, very similar to Parkinson's. The disease is caused by something like this, just the same way. And it actually has its own BRAC model. BRAC himself, Heiko Brack, created the BRAC stages for Alzheimer's, and that's still used just the same as it is used in Parkinson's. And we demonstrated with that analysis that it isn't so much this what drives whether or not you're going to have dementia or not, but something else. And to demonstrate that, I have been prepared for this, and I brought something that will illustrate what this used to be. This is how the proteins normally are. The proteins are in a state of solubility, and that's because they need certain properties to operate in a three-dimensional way. That's how proteins work. They must be soluble. What happens, however, is that when proteins encounter something that isn't there, let's say something like this. This happens to be a little bit of chocolate that shouldn't be in the brain. Then proteins are exposed to it and undergo a transformation from soluble to insoluble, from functioning to no longer functioning because they have turned into amyloids. The amyloids are the state of the protein that's essentially what I mentioned earlier. So what happens is that this is no longer available for use because the configuration of the protein is, as I mentioned, very tight. It's the cross-beta conformation. So what we demonstrated is that when we measure how much is there of this in the brain and compare it to how much it is of this in the brain, it doesn't matter how much you have of this, doesn't matter how much you have of this available. What matters is how much of this you in fact can demonstrate to have. So if you have a lot of this, which seems bad because that would be your brain is filled with amyloid or Lewy pathology in the case of Parkinson's, if you have your brain still is making enough protein, then you are expected to do well. So that is a source of hope for us, because it means that even if we don't know what this is, typically this is going to be invisible, because in fact we're dealing with common denominators. We're dealing with proteins that transform from normal to abnormal, from soluble to insoluble, from functioning to non-functioning. But we're missing this. This is ultimately the source of precision medicine. This is what varies from one person to another. But before we get to this, which is what CCBP is about, and we'll talk about that next, what we could do is rescue therapy. We can get more of this to the brain. Notice that would be a very different strategy from what we're trying to do, which is trying to get rid of this, trying to get rid of this. It isn't working. It is chasing a tail that has nothing to work. And perhaps it may be harmful because, as I mentioned to you, when you get this, if this is what's happening to fend the brain's fending, this might very well be a protective strategy. And some of our studies have shown that, in fact, that could be the case, that people who age for as long as they do beyond normal lifespans, centenarians, may in fact be able to age as long as they do because they are able to do this, preventing this, whatever that is, from ever taking hold in the brain. But because they happen to have probably genetic mechanisms that continue to create a lot of this stuff. So that's the greatest hope. And in fact, we have been working with colleagues at Karolinska Institute. Here in Cincinnati, Andreas Turkio is leading the effort, and in Karolinska, Karim Esset, a biophysicist that I have had the pleasure of meeting. And I think, Ben has also learned from him tremendously. I certainly have begun to use biophysical language thanks to him. And in fact, this example, I think, is inspired in many ways by what I have learned from him. All of this collaboration is making us think of a future in the next 4 to 5 years where this could be translated into humans with Parkinson's. And if so, then we will be able to stop progression of Parkinson's while we continue to understand what is it that is driving Parkinson's and Alzheimer's and other neurodegenerative diseases in each individual, depleting normal proteins and making it these little pieces of tombstones of what they used to be.
Amazing. So that brings us around to the future and where we hope to go and what we hope to achieve here there in Cincinnati and what we're doing with the CCBP. And I think, as Alberto was alluding to, it's kind of a twofold strategy that we see. This replacement strategy combined with precision medicine. And precision medicine is really something that has been embraced in other fields like oncology, as Alberto was saying before, with breast cancer. With cystic fibrosis, they've had tremendous success because of the new way of looking at things and the new precision medicine techniques that they've come about using. And now we want to apply those same lessons to neurology, which is what we're doing with the CCBP. And we can go over some of the things that we've been learning, some of the things that we've been doing so far. But I guess, Alberto, I'd like to start by asking, when you were told by that benefactor of yours in Cincinnati to do what do you need to do? What do we need to do to actually tackle this disease? Why do you think that shift in mentality was so important? And more to the point, how can we get more people to adopt that kind of open mindset? Because right now, what I see in a lot of other fields and a lot of other places around the world is that everyone is very limited in the questions that they can ask and in the scope of the studies that they can perform. Whereas here in Cincinnati, thanks to the generous support of the benefactor that you mentioned, we've had the liberty to think a little bit more long-term and to think a little bit more outside the box. And that's what led us to the CCBP and to everything that we're doing now. What do you think can be done to kind of spread these ideas a little bit further and to infect others with the the optimism that we see and the real way forward that we have with the CCBP?
Thank you, Ben. That's it's a very important question, and I have to admit I can only think that the answer is not going to be simple. I wish I could say it will require for us to finally accept that Parkinson's is not one disease, but this seems self-evident. We have all already accepted the idea that Parkinson's is not one disease, but I think it hasn't translated into acting as if we mean it. And we need to make that transition. So what's going to get us there? I think that it will be pressure from the outside, and the outside pressure means pressure from people who, like you, are becoming keenly aware that that doing the same thing time and again, seeming to change one intervention for another, but ultimately continuing the same strategy, it is futile, and perhaps beyond futile, harmful. I have hinted to the idea that if we look at the studies done, it's not just that those studies are showing futility. The studies are showing that there truly is a detriment in people who are receiving the experimental interventions, in many cases, compared to those in the control arm. So it begins to be problematic to continue adhering to an idea that can only be tested time and again with collateral damage. The patients are getting harmed by these studies. And by the way, this is a reason why so one strategy, and when I'm talking to patients, I'm asking them to be critical with any studies that they are offered that relate to disease modification. There are many trials going on that help us move us into a better state of symptom treatment. But when it comes to disease modification, which is the topic of our discussion, I hope that patients ask the question, why me? Why should I be the person targeted by this particular intervention that the trial is for? And if the response is because you have Parkinson's, because you have early Parkinson's, or because you have Parkinson's and you can be off any other medications, that's not a good answer. You want to know, what is it about you biologically that makes you, and perhaps few others, eligible for that study? And if that doesn't exist, then I think it's a problem. So what I think is going to get us to the next level, Ben, is if somehow we are successful at depleting these studies from people, starving them from people. Because I think if there is enough of a movement among patients, and you know what, clinical trial participation is good as an idea, but we cannot keep on participating on clinical trials just because they are trials and just because they seem like we should do it. And of course, our people with Parkinson's are so generous and selfless that they want to participate in trials. But I think we need to put a moratorium on any trial that doesn't match the intervention to individuals suitable to benefit from that intervention. And if we get there, that's going to be the first step of a change. It really requires that kind of a cultural change. And that's a story that we present in Brain Fables, Ben, is the idea that the field of oncology had these shocks, right? They want to believe that breast cancer was one disease until they had this one terrible study, in the sense that it didn't show what they thought, that the radical mastectomy was the only way forward for all breast cancers. It showed that if you do breast preserving surgery, there are as many people that survive than people who died, right? And they could have done more studies because they could have been insisting that they actually knew the answer was that the radical mastectomy was the way to go forward. But instead, they just accepted that maybe breast cancer is not one disease and stopped doing the same study time and again, or the same approach to breast cancer time and again. That's how they moved. And that's how we now know that 75% of all breast cancers fall into 20 different biological classes, each of which is treated differently. How can we get there is going to require the similar shock in our field. And also the they move away from the idea that because the brain is so special, we're exceptional, and that biology follows a different set of rules in the brain than it does in the rest of the body. It really doesn't. Biology is biology, and it operates in every organ system just the same. The only fragment of precision medicine in neurology is neuro-oncology. The treatment of cancers in individuals with neurological disorders, it follows the principles of oncology. No two people with glioblastoma multiforme are the same. No two people with any other kind of cancer are the same. How can we make that change? I think it'll be in part because there will be so much pressure from different organizations to changing, because the continuing to doing the same isn't sustainable, that will eventually have to change. But we've shown that we're very comfortable trying to keep on doing the same, right? Doing the same is easier. Changing is hard. And I think pressure from you and members of the Parkinson's community will be very, very critical for this change to occur.
Yeah, I agree. I think a lot of this is really in the hands of patients. We have to be, I think, a little bit more demanding about what we want. And as you said, question everything. Question why we're being put into this study. Question why our doctors are giving us any kind of medication that they give us, and especially when they sign us up for, or they recommend a clinical trial. Be very critical about what they're recommending. Ask questions, and try to take as much ownership of your own disease course as possible along the way. Now, I think we should start to talk a little bit more practically about the CCBP and what it is that patients actually experience when they enlist in it. We have, I think, right now 265 patients in our study. We're very happy to have gotten to this point, but we still have a long way to go in the study. Can you talk a little bit about the patient experience itself? What do patients actually go through when they sign up for the study, and what are they signing up for?
Yes, thank you, Ben. So the study of CCBP is a study that is only a once a year involvement by the patient. So it's about 3 to 4 hours total every year. And it requires a variety of different measures, but the three sources of information most important are extracted from blood, urine, and stools. Of course, the stool just requires, as the only part that is a little unusual, it requires for people to have a stool collection kit that we provide, so that can be brought to us at their convenience. And then in the background, of course, that information is going to be processed. There is really nothing further than that. So it's not going to be too taxing, I hope, for most people. We hope to keep it as minimally time intensive for people, so that then we have as many as possible. The idea here is to identify why any individual has the condition he or she has, not for what it can inform others, but because of what can inform the individual in the study. We, in fact, are laser focused now in defining the bioassays that will be linking people to therapies that we already have. So that in a future, even though right now we said this is an observational study, we're not really intervening at all. In the future, we hope that we will bring to those that are being selected from the work done in the background as candidates for a therapy or therapies for which they happen to have the biology to, in fact, benefit from. So we are filling the gap that the clinical trials never did, of using an assay of each of the therapies that have been developed over the last 4 decades to identify the best matches for those therapies. We recognize that, of course, that will be something that will require retail medicine application. It's only going to be few individuals at a time. Do you want to make a comment, Ben, on this?
I was just wondering, if possible, the people in the backstage, could we bring up the CCBP website or even just the CCBP URL? And if anybody is interested in learning more about it, you can go to ccbpstudy.com. That's ccbpstudy.com for anybody who wants to learn more. And if we can bring up even just that homepage image, that would be great.
Yeah, actually, that's a beautiful webpage. ccbpstudy.com was the brainchild of Ben, and we've received tremendous feedback from it. It's such a great overall website that I think will not only provide information meaningful about what exact steps and information related to the logistics of the trial for people, but in fact also will be one in which you have background information on other topics. And I think the most special part of the website is the tab for a set of blogs that Ben has also helped us put together, and that I think people will greatly enjoy as well. So if you have the time later today, ccbpstudy.com will be the place to visit.
And yeah, I guess we can wrap up by talking a little bit more explicitly about the future and this idea of matching a specific therapy to a specific patient cohort. And that's ultimately the goal of the CCBP program, is to get the patients that are in the study, as well as the greater community and really the whole Parkinson's community at large, to embrace this idea that we need to start understanding what's wrong with individuals on an individual basis so that we can match the therapies that we have and some of the therapies that we'll continue to develop to the individual's biology. And this, to really hammer home this point, so we've noticed, we've had, I think, 20 failed phase 3 clinical trials in Parkinson's so far. When we look at some of the data and we examine it a little bit more closely, we noticed that there are some people in each of those studies that responded beautifully to the therapies in question. But because it was tried on everybody that had Parkinson's, it failed. If we were able to go back and identify who those individuals were and just give it to those people, or just find people that were enriched with a certain biological marker that those people shared, our chances of success in the future going forward will be much greater. So I guess, and that's really the path that Alberto is laying the groundworks for here in Cincinnati, is that future of a precision tailored approach to neurodegenerative diseases. And Alberto can speak about this much more eloquently than I can, but that's what really brought me to Cincinnati. That's what really enticed me to the work that he's doing and to writing this book with him. And that's the future that I hope we're laying the foundations for here in Cincinnati, something that I hope becomes a global movement. But yeah, with that, Alberto, whatever you want to say for the final 3 minutes, the floor is yours.
Well, thank you, Ben. I recognize that this series of conversations are very different to what you will hear in other centers. As of now, Cincinnati, in terms of the CCBP as an expression of this change needed, is an outlier. These concepts that we discuss today are still fringe concepts, but they are slowly gaining traction. There are colleagues elsewhere that are looking upon the experience of Cincinnati and the research that we've been doing, and many of those forthcoming, that will, we think, change this for the better. Cincinnati hopefully will not be the only city doing this. There will be other cities. In fact, Ben is trying to help to extend the wealth of Cincinnati's initial foray into precision medicine to Toronto, and there is an interest in perhaps doing the same thing in San Diego, with the Summit Foundation has sort of hinted at the idea of creating CCBP there. So these ideas, I hope, will spread. We already have interest from patients living other parts of the country wishing to come to Cincinnati to participate. Of course, that's problematic, but it'd be easier if this idea is replicated elsewhere. I just want to end to a couple of things. One is that if anybody has any questions about any of this, feel free to email Ben and I. I'll take the easy questions. Ben take the hard ones. And if you want to come and visit us in Cincinnati and see what we have, I'm sure that many of you in the audience know roughly where we are and how proud we are of having CCBP. But certainly we're always keen to show you around and show people that wanted to visit us for sure. And I hope that you will read Brain Fables. I'm told by some that perhaps certain chapters are a little bit too technical perhaps. But the idea was to make sure that the data that has been used to create the idea of Parkinson's as we've conceived it is really looked upon very critically, not necessarily because the data points need to be understood precisely, but because of how important it is that we looked upon that as a way to change him, because his story as created is being fable, hence the title Brain Fables. But if we start working on those principles as we articulated here, the future is very bright, and hope will be based on real scientific findings and not on just irrational albeit beautiful and compelling ideas. So I thank you, Ben, for being part of this. And I thank you, Chris, also for letting us be part of your Saturday morning. And many, many thanks for this opportunity. Thank you, Chris, and thank you, Ben. Wonderful being with you both.
Well, thank you, Dr. Espay, and thank you, Ben, as well. We really appreciate it. We feel so lucky here in Cincinnati to be so physically close to the work and the efforts that you guys are involved in. And Ben, we look forward to your next visit back to the Queen City, and we appreciate you being an ambassador, an international ambassador for the city of Cincinnati.
Go Reds!
I'm struck that your this groundbreaking work that you do gives us a message that's so full of hope. It's a clear manifestation of the UC Health message that we see on billboards and in commercials here in the Cincinnati area. In science lives hope. And I will encourage everyone, find a way to get your hands on a copy of Brain Fables, and I might talk about that a little bit later in our program. I'll remind everybody that you can place your questions for Ben and Dr. Espay and for Dr. Dobkin in the chat window that you can access at the bottom of the screen. We do have a number of questions that have come in already, and after a short break, we will have our panel discussion. So we're going to take about a 15-minute break, and again, encourage you to take some time during that break to visit our sponsors, our presenting sponsor, Adamas, and our partner sponsor, Supernus, in the sponsor and exhibitor hall, as well as the 10 or 12 exhibitors who provide their products and services to our community, and we hope you can learn a little bit more about them there. So we will see you back here in about 15 minutes, so that would be 12:05, and go have some fun.